So let us discuss about the jaw relation. Any positional relationship of mandible to the maxilla. That means how mandible connected with the maxilla. Okay, so jaw relation are classified in three basic ways: orientation jaw relation, horizontal jaw relation, and vertical jaw relation. They have subheadings. We will discuss them one by one. Let us discuss first orientation jaw relation. Okay. So orientation jaw relation is the jaw relation when the mandible is kept in its most posterior position. It can rotate in the sagittal plane around an imaginary transverse axis passing through or near the condyle. As we have discussed in previous slides, there are hinge axes that pass through the condyle from right side to left side, and through these condyles, while moving the mandible 13 degree, and there is opening of incisal area 22 to 25 mm. Right. After that, there is translatory movement. Before that, it is pure rotational movement. Right. So in orientation jaw relation, the mandible is kept in at its most posterior portion. It can rotate in sagittal plane around an imaginary transverse axis passing through or near the condyles. Okay, I think it is a little bit difficult, but when we compare all these three, we will get something. Okay, so first we require for orientation jaw relation is the FACEBOW. So what do you mean by FACEBOW? FACEBOW is a caliper-like instrument used to record the spatial relationship of maxilla to some anatomic reference points to points, and then transfer this relationship to articulator. Let's first of all, I'll give you basic review of that. First, we will record the angulation of the maxilla in relation to base of skull. That we record with the help of the FACEBOW. Then that record we transfer it into articulator. Okay. So first of all, what are the parts of the FACEBOW? Let us discuss them one by one. You can see over here, it has U-shaped frame. This is U-shaped frame. Then is your condylar rod. These two are condylar rod. Then your bite fork. This is your bite fork. Here you can see clearly bite fork. Okay. Then your locking device. These are the locking device. Then your orbital pointer with the clamp. This is your orbital pointer. Orbital pointer. Right. So one section represents the plane of the cranium. This U-shape frame represents the plane of cranium, right? And the second section represents the plane of the maxilla. That is your bite fork. It represents plane of maxilla. Right, the third section, which is lock. The first two sections, without altering their plane, locking devices. Third one is your locking device, right? So now there are various types of FACEBOWs. There are two basic types. One is kinematic and other is arbitrary. Arbitrary are of different types: fascia type, earpiece type, slide-o-matic type, Geissy FACEBOW, Twirl bow, and whip mix FACEBOW. Okay, so first we will discuss about the anterior reference points and posterior reference points. Then we will discuss these, all the face bows one by one. First is your orbital. This is your orbital point, which is lower border of the orbit at the midpoint. Then your orbital -7. This represents the Frankfurt plane. Then your nasion. Then your Elof nose. Then your Denner reference plane, which is 43 mm superior from the lower border of upper lip, which is used for Denner face bow. Then your posterior reference planes, Baron's point, 13 mm. This is your Baron point, which is 13 mm anterior to the posterior margin of tragus of outer canthus of eye. Then your Geissy point, which is around here, 13 mm anterior to anterior margin of external auditory meatus. That's why it is written 13. Then your Snow's point, 11 to 13 mm anterior to tragus, this one. Then your Denner's point, which is 12 mm anterior to posterior border of tragus, and 5 mm inferior to line from external auditory meatus and outer canthus. Then your Bergstrom's point, which is 10 mm anterior to external auditory meatus and 7 mm below the Frankfurt horizontal plane. So it is written as 10, 11, 12, 13. You can remember them with the measurement, right? Then come to your kinematic face bow. So what do you mean by kinematic face bow? Kinematic face bow allows for the precise determination of the patient's hinge axis or terminal hinge axis. We call hinge axis terminal hinge axis also. So this face bow is generally used for the fabrication of FPD, and it is generally not used for complete denture fabrication because it requires a long and complex procedure to record the orientation jaw relation. It is very much accurate, that's why we use it in fixed partial denture and full mouth rehabilitation cases. So what we will do in this, the face bow helps to orient the cast in the patient's terminal hinge axis. Hinge axis is the imaginary line around which the condyle can rotate without translation. As I discussed before, terminal hinge position is the most retruded hinge position, and it is learnable, repeatable, and recordable. It coincides with the centric relation. Okay, pure rotational moment you will get when there is 12 to 15 degree movement of your condyle, right? And there is maximum incisal separation of 20 to 25 mm, which I have already discussed. Okay, true hinge axis should be located and marked before using the face bow, right? So what we can do is, in kinematic face bow, we record pure rotational movement, right? Then come to your fascia type bow. In case of fascia type, we will place somewhere around here. Exactly, I will tell you later on. It is most commonly used, okay, most common, because it does not require accurate measurements, right? The hinge axis is approximately located. It provides approximate hinge axis, and the condylar rods are positioned approximately 13 mm anterior. ठीक है? 13 mm. 13 mm anterior to auditory meatus on a line running from outer canthus of the eye to the top of tragus, also called canthotragal line, right? The FACEBOW takes its name from the fact that it rests upon the face, like your kinematic FACEBOW. Fascia type FACEBOW mainly use Baron's point, Bergstrom point, and Geissy point. I have discussed these points already. Then come to your earpiece type. So as the name indicates, the condylar rods, we have to place it in ear because they have earpieces. This type of FACEBOW use the external auditory meatus as an arbitrary reference point, which is aligned with earpiece, right? So in earpiece, the posterior reference point is external auditory meatus, and the anterior reference point is orbital, somewhere around here, right? In fascia type, the posterior reference point is orbital. Now come to what is the difference between the kinematic FACEBOW and arbitrary FACEBOW. So in kinematic FACEBOW, we will get accurate readings, accurate orientation of maxilla, right? In case of arbitrary FACEBOW, we measure arbitrary landmarks. In case of kinematic FACEBOW, the bite fork is attached to mandibular rim, whereas in case of arbitrary FACEBOW, bite fork attached to maxillary rim. It is time consuming. That's why we will use it in case of full mouth rehabilitation and FPD, right? It is easy and quick. That's why it is used very commonly, right? Advantage being more theoretical. It is practically a lot. Determine orientation, jaw relation, and centric relation both. It determines only orientation jaw relation, right? This is used for full mouth rehabilitation and this is used for complete denture construction, right? So what if orientation jaw relation is not considered? If we will not consider the orientation jaw relation, the maxillary cast is positioned without the correct maxilla hinge axis relationship, and the arcs of movement in the articulator will occur with which differ from those of patient. So there is a difference between the hinge axis, which we transfer from patient to articulator. Then an occlusion that is restored to an incorrect arc of closure or opening axis may have interceptive and deflective tooth contact. That means there is no proper intercuspation after the jaw relation. Such contacts are undesirable in either natural or artificial occlusion and can contribute to periodontal trauma, muscle spasm, and TMJ pain. Patient definitely will feel discomfort. Then come to your vertical jaw relation. So what do you mean by vertical jaw relation? It basically means the vertical dimension. Vertical dimension refers to length of the face. That means if this is your face, then we have to take the jaw relation in terms of vertical dimension of face, right? It is maintained either by occlusion of the teeth or the balanced tonic contraction of the opening and closing muscles of mandibular movement. Now, vertical jaw relation, as I've told you, we will take the vertical jaw relation in terms of vertical dimension. So this is a vertical jaw relation. If it is inaccurate, then it will cause strain in the joint. Vertical dimension of face is determined the amount of separation between the maxilla and mandible in a frontal plane. Definition states that the length of the face as determined by the amount of separation of the jaws. right? So there are two basic things in vertical jaw relation: vertical dimension at rest, which we call as VDR, and vertical dimension at occlusion. So you can see in both the pictures, there is here maximum intercuspation, and here is separation. So let us discuss them one by one. What do you mean by VDR? It is vertical dimension at rest. So the length of the face when the mandible is in rest position. That means mandible is in rest position. There must not be any strain. This is the position of the mandible in relation to the maxilla when the maxillofacial musculature are in state of tonic equilibrium, right? There must not be any strain, right? It is essential to record the vertical dimension at rest. So vertical dimension is at rest is equal to vertical dimension at occlusion plus freeway space. What does it mean? Like, vertical dimension at rest should be recorded at the physiologic rest position of the mandible. In patient with prolonged edentullousness, mandible shifts to a habitual rest position. Complete denture should not be fabricated using the habitual rest position. Therefore, the physiological rest position should be determined in these patients before recording vertical jaw relation. So how do we determine? First, we will record it by very easiest method, facial measurements after swelling and relaxing. The patient is asked to sit upright and relax. Two reference points are made with a triangular piece of adhesive tape on the tip of the nose and tip of chin. The patient is asked to perform movement like wetting his lips and swallowing, right? Once the patient perform the above mentioned movement, the mandible will come to its physiological rest position. Or very easiest method, we will ask the patient to say repeatedly, pronounce the letter M. Letter M. Right? Then come to your VDO. So what do you mean by VDO? That is vertical dimension at occlusion. So vertical dimension at occlusion is a constant position and can be maintained for indefinite time. Unlike the vertical dimension at rest, the mandible need to be in centric relation while recording this relation. Right? The mandible and maxilla relationship established by the repetitive contracted length of elevator muscles determines the VDO. So this is your maximum intercuspation. This measurement is VDO. Right? Then come to your freeway space. So what is freeway space? Look at these two pictures. So what is freeway space? Both these relationships, that is VDO and VDR, should be recorded in a normal dentulous patient. The teeth do not maintain contact at rest. The space between the teeth at rest is called the freeway space. You can see here the maximum intercuspation, and it is vertical dimension at rest. So the space while maintaining the rest is freeway space, which is around 2 to, in case of class 1, it is 2 to 4 mm. In case of class 2, it is 4 to 6 mm. In case of class 3, it is around 0.5 to 1 mm. So recording of occlusal positions, there are two ways, mechanical and physiological. Let us discuss them one by one. First is your physiological method. In case of physiological method, physiological rest position is first given by Neuswonger. It is not considered as an accurate method because it requires patient cooperation, which is variable and alters in jaw relation during the procedure. So what we will do, upper and lower occlusal rims, which were modified according to clinical guidance, are inserted in the patient's mouth and ask the patient to swallow and relax. When the relaxation is obvious, the lips are carefully parted to reveal the space present between the occlusal rim. The space is called freeway space. Okay, like this is your upper rim, this is your lower rim. While relaxation, there is a space. This space is called freeway space. The space between the occlusal rim should be 2 to 4 mm. So that's how we will calculate VDR is equal to VDO plus FWS, that is freeway space, right? Then come to your second method, which is Silverman's closest speaking space. In this case, when sounds like sh, s, j are pronounced, right, the lower incisor should almost touch the palatal surface of the upper incisor. Okay, this minimum amount of space between the upper and lower teeth in this position is called Silverman's closest speaking space, right? This is the second method. Then come to your phonetics. With the phonetics, we will ask the patient to say F, V, and S. This involves observing the movement of oral tissue during speech and, more importantly, listening and analyzing the speech of the patient. The maxilla and mandible show a characteristic speech relationship during speech. This can be used to determine the vertical dimension, right? Then come to your aesthetics. Aesthetic can be used to aid to determine the correct vertical dimension. This is done by selecting teeth of same size, right? Teeth of same size as the natural teeth, and by assessing the amount of residual ridge resorption. Right? Then come to a swallowing threshold. A conical occlusal rims are made of soft wax, is fabricated on the mandibular record base. Right? Then the upper and lower record bases are inserted in the patient's mouth. Salivation is stimulated and the patient is asked to swallow. The height of the conical wax rim is reduced due to pressure developing while closing the mandible during swallowing. The conical wax rim may also be softened to reduce the resistance to closing. This is how we perform swallowing threshold. The lower one should be made conical, right? Then come to your mechanical methods, ridge relations. So in case of ridge relation, we use two methods: distance from incisive papilla to incisor. Second is ridge parallelism. First is incisive papilla to incisor. In this case, the distance of the papilla to maxillary incisor is 6 mm. This one. Okay. Then vertical overlap between the upper and lower incisor is 2 mm. Right. Then the distance between the incisal papilla and the lower incisor will be approximately 4 mm. This one. Right. Based on this value, vertical dimension of occlusion can be calculated. Very easy to use. Ridge parallelism. The mandible is parallel to maxilla only at occlusion. The mandible of the patient is adjusted to be parallel to the maxilla. The position is associated with 5-degree opening of the jaw in the TMJ, right? Which is considered as the correct amount of jaw separation, 5 degree at the TMJ. Correct amount of jaw separation, which is pre-extraction records. Various pre-extraction records like profile photograph, profile silhouettes, radiographs, articular casts, and facial measurements can be used to record the vertical dimension at occlusion. So first is profile silhouettes. The word silhouettes means the outline, right? So it can be used as a template since the silhouette is taken from a pre-extraction radiograph. It shows the vertical dimension at rest. It is positioned on the patient's face while recording the vertical dimension at occlusion. And the chin should be at least 2 mm above the level of lower border of silhouettes. Okay, this one, 2 mm above. Then come to your radiographic assessment. In this case, cephalometric profile radiograph and radiographs of condylar fossa are used to determine the vertical jaw relation, but their use is limited due to inaccuracy technique. Then come to your articulated cast. When the patient is dentulous, the maxillary cast is mounted in the articulator using a FACEBOW transfer, which we have discussed already. An interocclusal record is made in the patient's mouth. Okay, the interocclusal record is used to articulate the mandibular cast with the maxillary cast. This is used as pre-extraction record. Okay, then sometimes we can use our former denture. Patient's existing denture is a valuable pre-extraction record. In this case, we use boil scotch. Boilage scotch is used to measure the distance between the border of the maxillary and mandibular denture when both these dentures are in occlusion. The measurement is used to determine the video, right? Then what is the difference between the freeway space and speaking space? The freeway space is interocclusal clearance, is described as space between the maxillary and mandibular occlusal surface when the mandible is in rest position, and it is 2 to 4 mm, right? In case of class 1, it is 2 to 4 mm. In case of class 2, it is 4 to 6 mm. In case of class 3, it is 0.5 to 1 mm. Now, speaking space is the space between the teeth during casual repetition of sound S. It is considered the closest relationship of occlusal surface and incisal edges of mandibular teeth to the maxillary teeth during function and rapid speech. This space, we will consider this space during functioning. That means muscles are in strain. While this freeway space, we will consider the freeway space in rest position, physiological rest position, right? Now, what is the difference between the... Now, let me discuss about two clinical implications. What if there is increase in vertical dimension and decrease in vertical dimension? Due to increase in vertical dimension, it causes trauma to the denture bearing area. Okay, increase lower facial height. That means aesthetics are not pleasing. Difficulty in swallowing in speech, definitely. Pain and clicking in TMJ, stretching of facial muscles, increased volume of oral cavity. That's how we can evaluate while increasing vertical dimension. If vertical dimension is decreased, it decreases the lower facial height. It causes angular cheilitis because there is more closure than the normal. Difficulty in swallowing again, pain and clicking discomfort on TMJ, which include headache and neuralgia, loss of lip fullness, which is again aesthetically not pleasing, obstruction of opening of eustachian tube that may cause pain in ear, loss of muscle tone, corner of the mouth are turned down, that gives appearance of edentulous mouth, decreased volume of oral cavity again gives appearance of edentulousness. So purpose is not fulfilled. Cheek bite because there is overclosure. Horizontal jaw relation is a relationship of mandible to the maxilla in horizontal plane, or it is the relationship of mandible to maxilla in anterior posterior direction. Horizontal relation can be of two types, namely centric and eccentric. So centric relationship denotes the relationship of mandible to maxilla when the mandible is its most posterior position. Right? And eccentric one is other than centric. Any relationship other than centric. So first of all, we will discuss about the centric relationship. Centric jaw relation is the maxillomandibular relationship in which the condyle articulate with the thinnest avascular portion of their respective discs with the complex in the anterior superior position against the shape of articular eminence. This position is independent of tooth contact. Okay, centric relation is most posterior relationship of mandible to the maxilla and the anterior superior relation of condyle to glenoid fossa. Significance of CR. Let us discuss that. We know that proprioceptive impulses guide the mandible movement. Okay. In dentulous patients, the proprioceptive impulses are obtained from PDL. PDL. Proprioceptive impulses. In case of dentulous patient, they are obtained from PDL. But in case of edentulous patient, do not have any proprioceptive guidance from their teeth to guide their mandibular movements. Therefore, the proprioceptive impulses for edentulous patient is transferred to temporomandibular joint. Right. Centric relation position act as proprioceptive center to guide the mandibular movement. Right. And there are some basic features of centric relation. What are those? These are repeatable, recordable, and learnable, which remains constant throughout life. Okay. It is definite learned position from which the mandible can move to any eccentric position and return back involuntarily. Basically, it is a center from which all movements can be made. Then methods used for recording centric jaw relation: tactile or intraocclusal check record method, functional method, Mayer's method, Patterson method, Needlehouse method, excursive graphic method, intraoral tracing, and extraoral tracing. We will discuss the important one from all of them. So first we will discuss the tactile method, wax registration bite. Basically the check bite method. It is the most commonly used method because it is easy, not time consuming, no need for complicated instruments or devices. This procedure make use of suitable wax interposed between the occlusal rim at the previously determined occlusal vertical dimension. Right. In this method, the tentative centric jaw relation is recorded by asking the patient to retrude the mandible. The casts are articulated based on the tentative jaw relation. Teeth arrangements is done and an intraocclusal registration is made. The tentative jaw relation is verified with intraocclusal records and errors are corrected. The commonly used material are zinc oxide, impression plaster, waxes, and impression compound. Right. Waxes are sensitive, so we prefer to use mainly impression plaster and zinc oxide usual. Right. Then come to your static or pressureless method. This is very interesting method. In this case, we use nick and notch method. What we can do in nick and notch method? Up to 3 mm of wax is removed on either side of mandibular occlusal rim from the premolar region to till the distal end. Okay. The depression created on the occlusal rim due to removal of wax is called trough. Right. Then 1 or 2 notches, these are notches, are cut on the corresponding area of maxillary occlusal rim. The notch resembles the V shape. Running totally across the width of the occlusal rim. One nick is cut anterior to the notch. This is also V-shaped, but does not extend through the width of the occlusal rim. Then, since the patient has learned to close his mouth with his mandible at its most retruded position, ALUX, this is your ALUX, is placed on trough created in the mandibular rim. 4 to 4.5 mm of ALUX should be placed on the trough so that about 1.5 mm of the ALUX will be projected during the mandibular occlusal rim. ZOE and impression plaster can also be used as a substitute, but it is good one because of temperature. Then ask the patient to close the mouth such that anterior part of the occlusal rim almost touch but not press against each other. The excess LUX present buccally and lingually should be trimmed off. Okay, care should be taken to prevent damage of occlusal surface of the nick and notch. Because we have already applied the petroleum jelly it will be easy to separate the rims without damaging the index, right? This is a nick and notch method, and we call it as pressureless method. Then come to your functional method, needle house method. This is again very interesting method. First, we will fabricate the occlusal rim made from impression compound. Then 4 metal beads. These are 4 metal beads or styli embedded into the premolar and molar areas of the rim. Right? The occlusal rims are inserted into the patient's mouth, and all the above mentioned factors affect the functional centric relations are considered. When the patient moves his mandible, the metal styli on the maxillary occlusal rim will create a marking. These are the marking on the mandibular occlusal rim. When all the movements are made, a diamond-shaped marking. Pattern rather than line is formed on the mandibular occlusal rim. The posterior most point of the diamond pattern indicates the centric jaw relation. This one. This is the posterior one. This one. Right? Then come to your Patterson method. Again, very interesting one. Here the occlusal rim made of modeling wax are used. What we will do, we will make a trench or trough. We'll make a trench or trough throughout the rim. 1:1 mixture of carborundum and dental plaster is loaded into the trench. This is your mixture. How we load it, you can see in the picture. 1:1 mixture of carborundum plus dental plaster is mixed and loaded into the trench. Then the occlusal rims are inserted. The patient is asked to perform the mandibular movements. The movements will produce compensation curve on the plaster carborundum mix. These are the curves. Right? These movements are made. The height of the occlusal carborundum mix is also reduced. The patient is asked to continue these movements until a predetermined vertical dimension is obtained. Finally, the patient is asked to retrude his jaw, and the occlusal rims are fixed in position with the metal staples. All right. Then come to our excursive or graphic methods. The graphic or tracing to record the centric jaw relation. These are of 2 types: arrow point tracing, and second one is your pantograph. These are of 2 types: intraoral and extraoral. Right? Let us discuss them one by one. So, first of all, we'll take intraoral tracing. You can see in the picture, the arrow point tracing is also called as Gothic arch tracing. Right? So, first we will discuss about the intraoral tracing assembly. Right? What is intraoral tracing assembly? That means there is something intraorally we have to see. So, first of all, we will discuss about the general concept. General concept of this technique is the pen-like pointer is attached to one occlusal rim. This is a pen-like pointer. This one. This is your pen-like pointer. We will attach an occlusal rim and a recording plate is placed on other rim. When the mandible moves, the pointer draws a characteristic pattern on the recording plate. The pointer is known as central bearing point. Okay. And the recording plate is known as central bearing plate. This is your central bearing plate. This is your central bearing point. right? Arrow point tracing form after recording horizontal functional movement. This is like this. Straight line arrow should be formed. Right? This is the general idea. Then here intraoral tracing assembly, the central bearing device is located intraoral and is more simple compared to extraoral arrow point tracer. The tracer is placed within the mouth, and the disadvantage of this method is the tracer is not visible during the procedure, and the size of the tracing is very small, making it difficult to determine apex of the tracing. So in this case, we will attach the center bearing point in the mandible and center bearing plate at the maxilla. Then ask the patient to do mandibular movements, and you will achieve this type of tracing on the maxillary plate. Extraoral tracing assembly, what we can do, the concept is similar like the intraoral tracing. The tracer have the same central bearing device attached to the occlusal rim. They have attachments that project outside the mouth basically. And recording pointer and plates are situated extraorally. Tracing can be examined as it is made, since the tracing pattern is also larger. Hence the apex can be identified very easily. Then your pantographic tracing. Just remember 2-3 points. It is 3-dimensional tracing. Okay, it is the most accurate method. Okay, to record the centric jaw relation, even eccentric jaw relation can be recorded using these instruments. These equipments are very sophisticated and are generally not used in fabrication of complete denture. Okay, this is because the complete denture have a relief factor that aids to compensation for the minor errors. These tracers are generally used for full mouth rehabilitation of the dentulous patient. So this is used for full mouth rehab cases. Right? Then your eccentric jaw relation. So eccentric jaw relation, it includes the protrusive and lateral relationships. The main reason is in making an eccentric jaw relation record is to adjust the horizontal and lateral condyle inclination in the articulator. This helps the articulator to reproduce eccentric movements of the mandible and establish balance occlusion. Okay, so eccentric relation basically is recorded using functional or tactile method. Method of recording eccentric are similar to the one used to record centric jaw relation. Rims, in case of maxilla, it is 2 mm below the level of upper lip for pleasing appearance. It is average 1/4 of an inch 1/4 an inch below the level of opening of, and its height is posteriorly 1/4 an inch below the level of opening of Stenson's duct. Lower level, in case of mandible, level of lower lip, occlusal rim should be at the level of lower lip anteriorly, and posteriorly 2/3 the height of retromolar pad. So there are various methods of teeth selection. First is your diagnostic cast, photographs, radiographs, teeth of close relative extracted tooth. Anterior teeth are basically required for aesthetic requirement. Posterior have basic function of mastication. So first is diagnostic cast. They are prepared before the extraction of the teeth. Operator can obtain an idea about the size and shape of the teeth from the cast. Okay, the actual size and shape required can be determined. By using this method. Then come to your photographs. With the help of the photographs showing lateral, anterior, anterolateral view of the patient should be taken before extraction. These photographs must show at least an incisal edge of the anterior region. at anterior region. Right? This method is useful to determine the exact width and outline of the teeth. Width and outline. Just remember these points. Okay. Radiographic errors are major limitation to this method. Occlusogingival height and the outline of the teeth can be recorded, but the contour and size cannot be accurately determined because the radiographs are two-dimensional. So we can record occlusogingival height and outline of teeth, right? Then teeth of close relative. The method is usually followed only if the other records are not available. That means it is a last choice. The size and contour of the patient, son and daughter's tooth can be taken as reference. Then your extracted tooth. This is the best method, I think, to determine the size of the anterior teeth. The exact detail about the size and contour can be recorded from this method. Size and contour. Right? There are various methods for the determination of size of the anterior teeth. One of them is Lyon-Williams method. This is a typical form and contour theory. The shape of the artificial tooth should be harmonized with the patient's facial form. Given by Lyon-Williams, it is not scientifically correct and undoubtedly the simplest and most useful guide. Shape of the incisors is similar to the shape of the face. He classified forms of human face into three types: square, tapering, and ovoid. What he told, according to him, the shape of the teeth should be inverse to the shape of the face. That means shape of teeth should be inverse to the shape of face. Okay. So that means if the face tapers downward, the teeth should be tapered upward, like this. The shape is like this, the teeth is inverse. Dentinogenic concept. Dentinogenic concept is given by John P. Frush and Ronald D. Fisher. So it is first described by Frush and Fisher. According to them, the sex, personality, and age of the patient determine the form of the anterior teeth. Okay. Sex, the form or shape of the teeth differs in males and females. Definitely. In case of females, the incisal angles are more rounded. Incisal angles are more rounded and angulation is very less in case of female. And in case of males, the incisal angles are rounded to a lesser degree. And teeth are more angular teeth. Right? So this is how it relates. Okay. Then come to your age. The age of the patient is important in teeth selection because of physiological and functional changes that occur in oral tissues. The patient can be either young, middle-aged, or old-aged. Due to decrease in muscle tone, sagging of the cheek, lower lips occur to prevent cheek biting. The horizontal overlap of the posterior teeth can be increased. Okay. And interocclusal distance reduced with age. The mandible teeth are more visible than maxillary teeth. Then come to personality. More squarish, larger teeth are selected for vigorous people. And it should be in flat plane for executives. Right? The quality of femininity, masculinity, and personality, and various physiological ages. Your teeth, size, shape, everything varies according to age, sex, and muscular tone. The secondary factors are tooth position. Dental matrices are called as dynesthetics. The dentinogenic procedure is the application of anesthetics by the dentist in sequence of aesthetic planning are according to the sex, personality, and age.